Hey there, friends. It's Ben, and this is our second part of our endocrine review for pharmacology. We're going to take a look at the thyroid, the adrenal glands, pituitary medications, and things like hormone and ADH, and some of those types of disabilities and disorders. And just real fast, if you haven't yet done this, go ahead and take a scan the QPC code here, that or the QR code that lets us know that you were here today, and that lets the great folks at Parkview Foundation know that you're utilizing our tutoring program and that you're finding the information helpful. It takes about 15 seconds, so I invite you to do that. You can also click on the link here. I've got our slides up here, or your review guide here, and I'm going to go through this pretty quick. It'll take about an hour, probably hour and 10. I'm going to go through some questions with you at the end and really try to capture what you need to know most on endocrinology. So I covered a lot of this on our first part of this, which was mostly on diabetes medications. And I'm just going to reiterate it because at first blush, endocrinology can really feel a bit overwhelming. There's a lot of different medications and there's different organs and different target glands and things like this. But keep it in mind that we're dealing mostly with glands, and so we're dealing with the secretion of substances. So if something's not, if a gland's not secreting enough, say insulin, we can tell it to secrete more insulin, or we can give substitute insulin. Or if it's secreting too much insulin, we can try to dial that back. Or same thing goes with thyroid. We can either try to give more, or we can try to dial it back, or we can try to remove the whatever's causing that. So sometimes we might have to remove a like a thyroid tumor or something like that if it's causing too much of something. So we're gonna that helps it a lot because we're basically flipping on and off switches. And so once we kind of look at endocrine medications as just adjusting the levels, trying to get the Goldilocks level, just adjust right, not too hot, not too cold, just right, then it makes a whole lot more sense and it's not so overwhelming. So let's take a look at a couple of examples here. So an example would be your thyroid. If you have too much thyroid, we have hyperthyroidism. Too much thyroid hormone is hyperthyroidism. And we'll see that in things like elevated heart rate. So we can give a beta blocker to turn down that heart rate, to slow down the heart rate. Or maybe they have too little thyroid. So we can give them some synthetic thyroid hormone like thyroxone. So we'll talk about some of these, levothyroxine. And so it's not too crazy. And so some strategies is just to review the pathophys of what the disorder is, just generally, like insulin and diabetes. Okay, diabetes, the insulin isn't working so well from the pancreas in type 2 or not at all in type 1. So, okay, just get a quick overview of your patho. And then look at your Saunders Comprehensive Guide. This is an older version, but yours will look some sort of like this. Use this book. It's got some really great resources in there. You can use an online version. It's got some great questions and it's a good summary. And then reread your notes and watch some videos. I've got some really good videos on the end here that help cover all this stuff as well. So just a quick 5,000-foot view of key endocrine disorders you should know for the NCLEX that keep popping up, at least in my experience in nursing school. So most of your NCLEX questions are going to come from things like these, especially diabetes. You need to know diabetes really well because, well, we have a lot of people that struggle with diabetes in this country, and we will treat a lot of people with diabetes. And the NCLEX knows it. So they're going to ask a lot of questions about it. So hypoglycemia is typically too little blood sugar or too much insulin. And how do we treat hypoglycemia? With carbohydrates, simple sugars. We want to go to simple carbs. So something like 4 ounces of orange juice, 15 grams of carbs every 15 minutes, and we check their blood sugar till we get it back up to where it should be, which should be somewhere between 70 and about 100 or 110. So 70, 110-ish. Hyperglycemia, that's going to be too little insulin, and we can have diabetic ketoacidosis or hyperosmolar hyperglycemic syndrome. You can watch that in part one. I go into really deep dive on diabetes. But today we're going to look at the pituitary gland and the two problems that we see with that. The first is with growth hormone, and the second with antidiuretic hormone. With growth hormone, we see acromegaly, and you can think about like acrobat. That's kind of somebody who's tall. Acro means high. That's what an acrobat is, somebody who's working like on a wire in a high wire, or mega means big, and so that's too much growth hormone. And dwarfism, and you can think of Snow White and the seven dwarfs, somebody who's short. Um, hmm. Sorry, quick coffee break. So we have problems with antidiuretic hormone, SIADH, which is too much antidiuretic hormone. And we have diabetes insipidus, which is too little antidiuretic hormone. We'll go in all these in just a minute. We have thyroid disorders, hyperthyroidism, which is too much thyroid hormone, which is Graves' disease. And the thing you really need to know about that is thyroid storm, which is like the thyroid is releasing way too much. And it's like hyperthyroidism on steroids. And so it's bad news. It's an emergency. On the other side of that, again, that Goldilocks thing, we have too little. And too little thyroid is hypothyroidism. And that concern is called myxedema coma. So that's another emergency. We'll talk about that here in a minute. For our adrenal gland disorders, the ones you really need are going to be Cushing's disease and specifically Cushing's syndrome. They look pretty much the same. The cause is different. We'll go into those a little bit, but that's going to be too much cortisol. And in Addison's disease, that's too little cortisol and other hormones that are being released from the adrenal glands. And the thing that you need to know about that is an Addisonian crisis. So let's do a deep dive. We're going to take a look here first at the thyroid gland disorders here. And so you have three major hormones that have to do with the thyroid. There's T3, there's T4, and there's TSH. And TSH is the thyroid stimulating hormone. And so it's the hormone that tells the thyroid, the pituitary gland releases it, tells the thyroid, says, hey, make more thyroid hormone. So, and so that comes in, and that means under like Graves' disease, for example, we're going to have really high levels of T3 and T4, and we're going to have very low levels of TSH because the brain is saying, hey, don't make any more. You're already making too much. Stop. Stop. And the thyroid gland isn't listening. It's just continuing to chug out lots of T3 and T4, despite not getting that signal from the pituitary gland. So, what happens in Graves' disease? We have hyper everything. I like to think of it as Graves' disease. So you get a party and everybody's like all happening and stuff like that. So that's Graves' disease. It's a rave. Everybody's high on stuff, right? So high blood pressure, high heart rate, high temperature, metabolism's high. People have weight loss. They've got bulging eyes like Steve Buscemi, this sort of um, echymosis that happens there. Enlarged thyroid gland. For women, it can be amenorrhea or facial flushing. Many years ago, when I was in college, the first time I worked for a vitamin store, I was the associate manager, and my manager, she had hyperthyroidism. She had Graves' disease, and so she had a little bit of the bulging eyes. She couldn't gain weight at all, and that really distressed her because as a woman, she had a very flat figure, and she's like, she wanted more, mass in certain places, and that wasn't happening for her. And she was very thin to the point where she was, taking lots of gainers fuel and stuff like that because she didn't have money for insurance because they didn't pay us very well. So she was very thin. She had that in fast metabolism. She had that high heart rate. She had a amenorrhea, that type of thing. So she had heat intolerance. She was always fanning herself. She had a fan there because she was always feeling overheated. And she would have had usually a very low TSH level because that's the hormone, the thyroid stimulating hormone is the hormone that says, hey, make more thyroid. And the thyroid's already making too much. So here's some examples of Graves' disease. Some more symptoms: heart rate, palpitations, increased appetite, weight loss, feeling shaky or nervous. Tremors is another way you'll see it in the NCLEX. Having diarrhea or frequent bowel movements. You think high and fast everything. So, fast bowels are diarrhea. Slow bowels are constipation. And the cause is primarily with Graves' disease is the TSH antibodies um, are being made, and they just stay on the T3 and T4 um, uh, receptors, and they just keep pushing the buttons, almost like a coked up mouse in a lab somewhere that just keeps pushing the stimulate button, and they just keep stimulating the hyperthyroidism all day long. It doesn't care. It's just like more, 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 more. It's an autoimmune response. And so what we need to do is we need to slow down the body's ability to make thyroid hormone. I mean, it's got plenty of TSH, it's got too much because of the antibodies that just keep pushing the button. So we use thiamides because they inhibit the synthesis of thyroid hormone. And you can think of methimazole, or trapezool is a trade name, but methimazole. And the way to kind of remember this one is I think meth and people being high on meth, and that makes you high, and you have the THI in there for thyroid. So methimazole is high for high thyroid, and then it's got the THI on there. And I think of THI as thyroid hormone inhibitor. Thyroid hormone inhibitor, THI. And then you have another one is I think that's propylthiouracil. It's oftentimes abbreviated as PTU, propylthiouracil. But notice that the word, you got thigh in there again. And so I think of THI in this term as thyroid hormone inhibitor. And that's not always going to be the case. You're going to have other medications that have THI in them. But for this exam, if you see methimazole and you see polypropyluracil and you're like, I can't remember what those are. If you see the THI, think thyroid hormone inhibitor. What they do is they inhibit the synthesis of the thyroid hormones. So teaching, methimazole can cause agranulocytosis. And if you remember, other drugs cause agranulocytosis too. And that means that you basically are going to have things like low white blood cells function. So they need to report things like signs and symptoms of illnesses and sore throat and fever, anything that says that they might be getting sick because their white blood cell numbers are going to start to tank sometimes. It can also take 3 to 12 weeks to stabilize the level. It's because the thyroid gland is a gland. So it's absorbing and storing all of this thyroid hormone. And it's going to take a while for the body to utilize all that. So it can take a little bit of time. The other options they have in here are going to be things like radioactive iodine, which destroys tissues, usually resulting in hypothyroidism, which you're like, oh, now we got to give medication for hypothyroidism. You're like, yeah, we do, but at least we can control that, where maybe we can't control the hyperthyroidism. It's easier to add more thyroid hormone to something. Same goes with surgical removal of part of the thyroid. My mom had this done. She was producing too much T3, T4. So they removed half of her thyroid, and then she was able to make, and a pretty accurate amount that she needed. I think she takes a little bit of levothyroxine, which we'll talk about in just a moment, which is a synthetic thyroid hormone. A beta blocker. Sometimes we need to give beta blockers to people with hyperthyroidism because it slows down the heart rate. Hyperthyroidism is everything is jacked up pretty high, right? So this helps reduce that. To remember, my little mnemonic here for beta blockers, they all end in OLOL. And so I think of little old ladies online taking them and they're going, LOL, LOL, on AOL, LOL. And that slows the heart rate and reduces the blood pressure. The emergency we need to worry about here is thyroid storm. So I made it red in your notes, and that's severe tachycardia. And we're talking like high 140 or higher. And at that heart, the heart is going boom, like lubbed up, but it's going lubbed up, lubbed up, lubbed up, lubbed up. It's going so fast. It's going so fast, probably like this, that it can't fill. And so what you get is you get heart failure. And you would think that somebody who's having a really high heart rate like this might have hypertension, right? Because all the blood that's being pumped. And the answer is no. The heart is moving too fast to fill up. It needs to move slower to get a good pump. Lub dub, lub dub. That's why, 60 to 100 is ideal. But at 140, it can't fill up. And so they have hypotension, low blood pressure, because the blood isn't going anywhere. It's like atrial fibrillation happening or VFib, that the heart is just not doing anything. So they will often have hyperthermia, not hypothermia, but hyperthermia. So that's really high body temperature. So we're talking 104 to 106. And that can lead to things like seizure, delirium, coma, death. And that's because they're not getting good blood perfusion, low blood pressure because of the super high tachycardia, and their brain is baking. So this is why it's an emergency. So it can be caused by stress, infection, surgery, trauma, illness, those types of things. Most often, it's going to be a result of surgery, and it happens from an overactive thyroid gland with a dose that's too high, or it can happen from a dose of too high on a medication like levothyroxine. Like my mom's on levo because of she has low thyroidism these days. And so if we give her too much, might have a thyroid storm. So that's an education piece. And so the treatment there is you want to maintain patent airway and adequate ventilation. Think ABCs. So airway and breathing, and then circulation, right? So that's going to be like a beta blocker. We want to control the heart rate. And then thiamide, which reduces T3 and D4. And so what is thiamide? Well, look here, you got the THI, thiamide medications. And if we go back up here, where are thiamide medication? Right up here, thiamide medication. So that'd be like methimazole. And you take THI for thyroid inhibitor because it inhibits the synthesis of thyroids. Kind of get it? Cool. So that's hyperthyroidism. And so we treat hyperthyroidism by typically removing part of the thyroid or killing it off. Now, the opposite of that, if we were to think Goldilocks here, is too little thyroid. And so that's going to be too little T3 or T4 hormone. And you'll get this in your pediatric or OB that it's called cretinism in infants. In case that pops up, you just might want to know that. So signs. So when it comes to signs of hypothyroidism, think low and slow. So it's low and slow everything. They're going to have a low heart rate. They're going to have low metabolism. And when someone has low metabolism, that means they're gaining weight. They're going to have fatigue. They're going to have constipation, slow bowels. That's constipation. They have hair loss. They'll have a goiter potentially, infertility, depression, trouble concentrating. And they'll have typically a low T3 and T4. That's the active thyroid hormones, but they'll have a high TSH level because TSH is the hormone that is released by the pituitary gland that tells the thyroid to pick up the pace, right? And so it's going to be, hey, wake up, thyroid. I'm trying to get trying to get its attention. We'll keep sending a signal, and so it'll do that through increasing the amount of TSH. But it's the thyroid's just not doing it. It's not making it happen. And so one of the things that it can cause is depression and this sort of low and slow fatigue. And so many times when people are getting screened for depression, the wise healthcare provider will go, I wonder what their TSH level is. And so they'll look and see, well, are we dealing with depression? Like, is this like a dopamine serotonin issue, or is this a thyroid hormone issue? And do they not have good thyroid function? Because if you look at a lot of these symptoms, feeling low, feeling slow, constipated, just bleh, they feel like depression, doesn't it? So like, okay, so they'll check that out. So the cause of that's going to be low thyroid hormone or missing or damaged thyroid. And maybe it's something that we cause because maybe like my mother, we took out her thyroid because she was making too much. So we give people who have low thyroid hormones synthetic thyroid hormone. Makes sense, doesn't it? Oh, okay. So what it does is it controls the metabolic rate in the tissues by increasing the metabolic rate in the tissue. And it's usually levothyroxine or thyroid. And you can see the word thyroid in the name thyro right here. So think about thyro. Um, and you might think of thyro. And I'm going to add in here just another note here. And hypo. Um, Thinking live for treating low thyroid. So you want to take this teaching every day, the teaching you want to give. They want to take it every day in the morning, first thing in the morning. And the reason you want to do that is like levothyroxine, we're talking 50 to 100 micrograms. I mean, that's like it's weighs less than a staple. It's an incredibly tiny amount of medication that we give people. And so if we give it to them on an empty stomach first thing in the morning, then we've minimized all the other variables that come along with things like absorption, right? So if they take it the same time every day, first thing in the morning on an empty stomach, then we should have consistent results. But if they take it after a big fatty heavy meal at the end of the day, who knows, right? How much of that will get absorbed. And we're talking such a tiny amount. We need to be really precise. So take it in the morning every day. It increases the actions of SSRIs and anticoagulants. And the SSRI makes sense, right? So we're treating the depression with someone. And so now they're not feeling as depressed. And then we give them an SSRI. So now we've bumped up that action. It decreases the action of insulin and hypoglycemics for patients with diabetes mellitus type 1 and type 2. So that means we need to probably give them a little bit more insulin or a little bit more hypoglycemic medication. That makes sense because we're revving up the metabolism. Um, and so their blood sugar is going to be a little bit higher. And so we're going to need to try to drop it a little bit more, potentially. They need to take it at least 4 hours before any. I didn't finish this thought. So this is going to be before any antacids. Antacids can absorb and change other medications and things like that. And we're talking again, tiny little amounts. So we want to be sure they get that full dose. They want to report any signs or symptoms of hyperthyroidism because that means we probably gave them too much. That's going to be rapid heart rate, palpitations, chest pain, excessive sweating. It means the dose is too high. And because now they have hyperthyroidism. And then we also want to monitor for signs and symptoms of hypothyroidism that are continuing because that means we probably haven't given them quite enough. And it usually takes about a month for them to reach that therapeutic level. And that's because the thyroid hormone the thyroid gland has to continue to absorb or the amount of hormone so it has that available. So it just takes some time. So maxedema coma is the concern we want to worry about with hypothyroidism. And that's going to be very low T3, T4 levels. We're going to see things like it's hypothyroidism. So everything's low and slow, but it's very low and slow. So it's like just a really bad case of hypothyroidism. So you got hypotension, you've got bradycardia, hypothermia, hypoglycemia, respiratory failure, and coma. And so its main treatment is going to be, again, ABCs, right? We're going to maintain that patent airway, aspiration precautions, so that's airway and breathing. We're going to give them some levothyroxine IV, which is that synthetic thyroid hormone. We're going to bump that up. We're going to give them some IV glucose to get their blood sugar back up. And we'll probably end up giving them some corticosteroids, which help to get the body kind of back. It helps it to respond to stress. So that's hyper and hypothyroidism. There's a pretty good video at the end here that you can watch. I've got a couple links for it on Simple Nursing and elsewhere. But let's move on quickly to the adrenal gland. And these pictures that I have come from Laterio, and I really like Laterio for pharmacology if you have a subscription for that. So this is a little hat. The adrenal cortex is a little hat. The adrenal gland is a little hat, rather. It sits on top of the kidney here, and it's like a little hat, little. Whoop. And then the cortex is going to be in the center of that hat, and kind of just on that. That's the adrenal medulla, but the cortex is going to be kind of on the outside, middle towards the top. But the corticosteroids, what comes from that, is going to be like stress response, immune response, inflammation, carbohydrate metabolism, protein catabolism. That's the breakdown of protein. Side note, this one's for free. So how to remember catabolism versus anabolism. Anabolic or anabolism means to build something up. And you think about the weightlifter who's like, and he's taking anabolic steroids. Anabolic steroids build up stuff. And then you can think about catabolism as breaking things down. And that's because cats are jerks. And every cat you have, they're just standing there like, oh, la, 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 meow, and they break everything, right? They drop stuff on the ground. They break things down because they're cats. I am a cat guy. I do have a dog too. She's very sweet. She's running around in the backyard right now. It also deals with things like electrolyte levels and behavior. So there are two main classes and types of corticosteroids. There are mineral corticoids, and there are glucocorticoids. Mineral corticoids and glucocorticoids. What do they sound like? Minerals and glucose, right? We're not wrong on that. Notice the term in there, cort, for corticosteroids. An example of a mineral corticosteroid is our friend aldosterone. And we've seen aldosterone before in the RAS cycle, RAAS, renin aldosterone angiotensin cycle or system, right? Yeah. And then we have glucocorticoids, which is going to be cortisol. So let's take a look at these again. So mineral corticoids, so aldosterone, that's our friend. You need to know aldosterone. He's going to pop up a lot in this lecture and in just in general. It's an important chemical in our body. It controls electrolyte and water levels, and it promotes sodium retention in the kidneys. Why is that important? What does sodium do to your blood pressure? It raises this, right? We have the DASH, which is the diet for reducing hypertension by reducing sodium. Your cardiologist is always telling people who have high blood pressure to reduce sodium intake, right? That's because it increases blood pressure, but we need blood pressure or we die. So there's the Goldilocks space, right? There's that happy, not too hot, not too cold, not too big, not too little, just right. Then we have glucocorticoids, and those control fat, protein metabolism, carb metabolism. They have anti-inflammatory effects. And so we often give them for things that are immune system related, like asthma. And then they also decrease eosinophil action. So those are kind of our go-tos for autoimmune issues too. So we're going to take a look at those in just a minute. So some systemic effects of excess glucocorticoids, we're going to see this with Cushing's disease and Cushing's syndrome, but it's going to be like a buffalo hump. And that's because it's an inappropriate way that the body is starting to create fat in the back of the shoulders here. Acne, because it increases androgens, muscle wasting. It's really weird the way that works, but it causes people's arms to get skinnier and them for the gain weight. Weight around the midsection, excessive sweating, steroid skin that bruises easily and tears. Sometimes people will see this in especially older adults, senior adults. Red or purple stretch marks, that's what striae mean. Suppressed growth in children. I have a brother-in-law, my sister's brother. My sister, I should say my brother-in-law, his younger brother had really bad asthma, so did his dad, and they're both fairly short for their stature, especially in comparison to my brother-in-law, who's about 6'2". They are, 5'3", 5'4", and that's because they were on a lot of corticosteroids as when they were younger due to asthma. Corticosteroids can also cause osteoporosis in bones, and it can also cause bleeding and gastric ulcers. And so excess can cause Cushing's disease. And so we're going to take a look at that right now. So Cushing's disease and syndrome is too much cortisol. Um, the main issues are going to be moon face, facial hair, mood swings, and buffalo hump. So you can do that with me if you want. Moon face, facial hair, mood swings, buffalo hump. Moon face, facial hair, mood swings, buffalo hump. They're also going to get that truncal obesity because they're releasing a lot of, or we're giving, or they're releasing a lot of cortisol. And cortisol is that stress hormone, and stress hormone makes you fat around the midsection. Um, and then they can cause hyperglycemia and hypertension. It also increases the amount of aldosterone, and aldosterone causes you to waste potassium and hang on to sodium. So you're going to have hypernatremia, high sodium, low potassium, and too much aldosterone also causes hypertension. So you're starting to see how this can create some other health issues, right? And so Cushing's disease is typically caused by too much adrenocorticotropin stimulating hormone, and so or ACTH, and so that's the brain telling the body to produce more, and it's usually a tumor. So it could be on the pituitary gland. I think there are some lung cancers that can cause ACTH releasing tumors and things like that. So that's Cushing's disease. Cushing's disease is caused by the body itself. Cushing's syndrome is something that we're doing to the patient, and that's caused by high doses and long-term treatment of corticosteroids. So that's going to be like in the case of a severe asthmatic, like my brother-in-law Danny. Um, and so um, I also had a secretary who had a former secretary many years ago. In my previous life, she had a very bad asthma and she had Cushing's syndrome, some of these symptoms. So she had a little bit more of the rounded moon face, a little bit more of the buffalo hump, some of the purple striae, and kind of this truncal obesity, and bone thinning and things like that. And I know she didn't like it, but it was basically, do you want to breathe or do you want to have these side effects? And so, she had to choose, unfortunately, that, and so it's a serious issue, and so one that requires some sensitivity on our part. So treatment for Cushing's disease is to fix the underlying problem in the case of a tumor. And in Cushing's syndrome, it's usually an unfortunate side effect of the corticosteroid medications that we're giving for things like asthma or other autoimmune issues. So we try to regulate that or try to use the lowest amount that we can get by with. That's the too much. Then we have on the other side of the Goldilocks, right? The too little. And too little corticosteroid is Addison's disease. And John F. Kennedy is a president a long time ago, before my time. I'm old, but I'm not that old. He had it was this, and he had bronze pigmentation of the skin and changes in like GI disturbances, weakness, hypoglycemia, weight loss, those types of things. Another thing that's not on this list that I've heard is a craving for salty foods because you have so low sodium. Your body's like, give me potato chips, give me something. I need to get my blood pressure back up. And our body does this sometimes. It'll start craving things that it needs. Like if you're hungry because you got low blood sugar, it's like, Snickers now. You're not you when you're hungry, right? So Addison's disease is too little cortisol, and typically along with it, aldosterone and androgen, because it can be affected by the all of the hormones that are being released there by the adrenal cortex. So it can also include things like fatigue, impotence, GI disturbance, because you're just not you. You don't have energy. Corticosteroids are what, cortisol gives you that thing you need to respond to stress in the short term, and that's a good thing. Helps elevate your heart rate when it needs to be, stuff like that. But you're going to have the biggest concern you have are dehydration because of the low aldosterone and hyperkalemia, and hyponatremia. So these people have high potassium and low sodium. And so you want to measure, anytime you see hyperkalemia or hypokalemia, I want you guys to be thinking potassium pump. And so if you ever see anything that's a potassium question, I want you to be thinking heart. It's almost always going to be something you got to be monitoring for the heart. So when it's hyper or hypokalemia, you want to be thinking P for potassium, P for pump. And if you see something that says hypo or hypernatremia, which is high sodium, I want you to be thinking brain. So thinking Na for sodium, and Na is also in the brain, BRA, right? So causes poor adrenal gland function. And so, how do we treat Addison's disease? We're going to replace the mineralocorticoids, which is aldosterone. We're going to replace the glucocorticoid, which is cortisol. And we're going to do things like use prednisone, betamethasone, methylprednisone, or dexamethasone. They all sound about the same, don't they? And look, they all end in SONE or LONE. Good tip, right? So if you see these, you have an idea, and we've encountered these before, like fluticasone in our medications for respiratory. That's stuff that people squirt in their nose, or inhaled bronchosteroids, right? They can have a lot of side effects. Hyperglycemia, a decreased immune system. Um, when you have increased aldosterone, we want to look for signs and symptoms of hypokalemia and hyponatremia. So that's going to be fluid retention and hypertension and edema. Let me repeat that, both of these. So um, we give corticosteroids oftentimes to decrease inflammation, but inflammation is it's an important part of our immune system function. We have it for a reason, but sometimes the body overdoes it. And so, but if we're decreasing inflammation and we're decreasing the immune system function, we're at risk for illness. Does it make sense? Okay. And then if we're increasing aldosterone, which is what this does too, we're going to start to get to those signs and symptoms of hypokalemia, because aldosterone causes us to um, it's going to cause us to increase our levels of potassium. It's going to cause us to hang on to more sodium. It's going to cause hypertension and edema, if that makes sense. Because that's what aldosterone does. It causes us to retain sodium. And that means we're going to get edema. We're going to get higher blood pressure. And those are sometimes things that we need, but we can overdo it. We can get Cushing's symptoms if we give them too much too, right? Adrenal glands, one of the things you need to know is they begin to atrophy after prolonged use. And so you must, this is the thing you need to remember, never quit. And you always teach your patients this. You'll see questions about this all the time. Never quit a corticosteroid like prednisone cold turkey, because you can cause an Addisonian crisis. You've got to taper it off. And you'll see this in medication doses of prednisone. I get that periodically for my asthma when I'm having a bad flare up, and I'll get 5 or 6 pills I take one day. The next day I take like I start with 6, and then I have 5, and then the next day I take 4, and the next day I take 3, and the next day I take 2, and the next day I take 1. And they're doing that to taper me down, because if I stopped prednisone cold turkey, I could go into an Addisonian crisis. Anybody can. It's a sudden onset of adrenal insufficiency. And so you want to slowly taper off corticosteroids. You can also cause it from stressors like pregnancy, surgery, illness, things like that. And it's signs and symptoms that are going to be no aldosterone. So if you have no aldosterone, you're not retaining salt, and it means you've got too much potassium. So you got hyperkalemia, too much potassium. You're not retaining salt, so you have hyponatremia. You have severe hypotension. You've got shock, severe headache due to the fluid changes in the brain because of the salt. You have irritability, generalized weakness, hypoglycemia, and again, hyperkalemia. And so this person, you want to be doing neuro checks on them because of the changes in the salt. And you want to be doing, having them on cardiac monitoring because of changes in their EKG. And so causes, again, illness, surgery, trauma, stress. There are periods when your body really needs more cortisol to adapt, but it doesn't make it. That's the problem. So we have to give it. And so we give it we give cortisol basically in the form of a corticosteroid. And we'll give IV fluids to and restore that electrolyte balance. So try to get that sodium down, that potassium back up. So the teaching here is never stop corticosteroids cold turkey. Hey, never. Yeah. Um, and if somebody's stressed and they need more cortisol, they might need to talk to their doctors during times of stress. Okay, take a breather. That's a lot. You guys are doing well. Okay, quick little coffee break. Wet the whistle, right? So we've got SI-ADH moving on now to our problems with anti-diuretic hormone. ADH is the hormone that causes us to retain fluid. I think of it as my anti-peeing hormone. SI-ADH means a way of thinking about it is soaked inside, or it's syndrome of inappropriate ADH. And so that means they have too much ADH. And so it's too much of the hormone that stops you from peeing. And so if you can't pee because you have too much of the hormone that stops you from peeing, you're just going to continue to retain water. So, that means your kidneys aren't really working. You're going to have sticky, thick urine. You're going to have increased blood pressure because you're retaining all this water. You're going to have really low sodium, which is a thing called dilutional hyponatremia. We'll talk about that in just a second. But you want to worry about what's going on with the patient's brain in this case because of the problems that are going on with their things, and also their lungs, because they could then be having things like pulmonary edema. And then we're going to take a look in a moment here at DI, which is diabetes insipidus. And you think about diabetes makes you pee a lot. That's one of the symptoms, diabetes. And insipidus, you can think about sip. You sip a lot of water. And in this case, you want to sip a lot of water. These people are dry inside. They can't drink enough water. They have dry skin. They're just constantly peeing to the tune of, I've heard up to 5 gallons. That's a lot of pee in a day. Decreased blood pressure and the like. So let's take a look at these one by one. So too much ADH is SI-ADH, or syndrome of inappropriate anti-diuretic hormone. And that's because you have too much of this hormone that won't let you pee. And so you're going to get fluid retention. So you're hanging on that fluid. It makes you soaked inside. So SI, soaked inside. You get that dilutional hyponatremia, which means that, yay, I might have the right amount of salt in my body, but I've got twice the water that I need. So now I've got half the amount of sodium I need because everything's diluted. Does that make sense? And we're really concerned about sodium because it plays such an important role of being a cation, the primary electron that we have in our bloodstream. And so we have low sodium, we can have cerebral edema, and that can cause seizures. So we want to be thinking neuro here. We can have fluid volume overload, which can be pushing fluid into our lungs. So we want to be thinking lungs. You can have hypertension, often due because there's so much fluid in that vascular space, and tachycardia. You can have weight gain without edema because it's like in your bloodstream, it's everywhere. You're going to have low urine output, so it's going to be sticky, concentrated. It's going to have a high osmolality, and it can be caused by things like head injury or pituitary gland surgery or tumor or trauma. And so you might see a question that says, hey, you need to be watching for this patient after some kind of brain surgery or a car accident or something. And so the treatment, you're going to put them on seizure precautions because of the fluid volume and the shifts of sodium in their brain. They can cause a seizure. So that's going to be things like having, oxygenation and ventilation at the side of the bed, padded rails, things like that. IV fluids, they're typically going to be normal saline or hypertonic and loop diuretics, and they'll probably put them on water restriction because they already have enough water. But they'll be trying to utilize those IV fluids to try to shift the fluid out of the body. And they'll be using diuretics to do that as well. So then let's move over here to too little ADH, the Goldilocks, right? Got too little, and that's diabetes insipidus. And so diabetes makes you pee a lot. So that's one of the 3 P's in diabetes. And so it's the case here. That's why it's diabetes in terms of peeing a lot. But you think insipidus, sip, like needing to drink. And so that's the way I remember that, too little ADH. Polyuria is the primary thing, and I've heard it can be up to 5 gallons because you have no hormone to stop you from diuresing or peeing. Side note, um, alcohol also lowers your SI or lowers your anti-diuretic hormone, which is why when you're drinking a couple of beers over an evening, you pee a lot more. It's not just because you had that extra pint or fluid, a pint of liter of water. It's because you're having that alcohol in it that is starting to dehydrate you, and that's part of the reason why you wake up with a hangover. So don't overdrink. Um, you're going to end up with low urine osmolality. It's going to be like 1.001, 1.003. Pure water is 1.0, just to give you an idea. So it's basically pure water. It's very little anything in it because they are so like just they peed out everything. Low blood volume, they're going to have low blood pressure, tachycardia, headache. And so we also got to worry about some neuro issues here because of the changes in things like hyponatremia. The blood has got a lot of salt in it because it's really concentrated. Um, and so we're going to worry about things like stroke or head injury or idiopathic stuff like that. So treatment of this, we're going to give synthetic ADH, which is going to be Pertessin, which is also used to treat hypotension in the ICU. It's a potent vasoconstrictor, if that makes sense. So we're going to clamp things down, which will increase the blood pressure, but it also causes you to retain fluids. And so you can think like it's pressing on my vasos. So vasopressin is pressing on my vasos, or your veins, or pressing on your bladder. It's going to like help you like retain fluids. Um, and then you can think of desmopressin, which is DDVAVP. Oftentimes you'll see it like that. And that's available as a nasal spray, but it can also other ways too. But it doesn't cause as much vasoconstriction. And so if you come across a question like between vasopressin and desmopressin, you can think, well, desmo does more than pressin on my veins. It doesn't have as much of that vasoconstriction. Teaching there, reflushing, headache. They may have problems breathing because we're missing now with trying to allow more fluid to stay in their body. So if we allow too much fluid to stay in their body too quickly, it might go to their lungs and that could recreate. Okay, we're into the home stretch here. Let's take a quick peek at the problems with growth hormone. With acromegaly, that's going to be too much growth hormone, and that's going to be like hyperpituitarism. You can see things like large hands and feet, large organs, deepening voice, joint pain, hyperglycemia, and it's caused by excess growth hormone, and it's often from a pituitary tumor. So the treatment oftentimes in there is going to be surgery. There's a class of medications that you can do, which is uh, octreotide. So octreotide and lanreotide, and you can look at the suffix here. I think of reotide, and I think he's Rio tired. Rio tired. Okay, it's a stretch. Rio tired. Rio tired. It's real tired from growing. And so that's one way to think about that if you see that in your exam, Rio tired. You can also might come across pegvisomant on your exam. And pegvisomant, I think of it as peg is so giant. Peg is so mad. Peg is so giant because it treats uh, acromegaly or giantism. Dwarfism is too little growth hormone, and it's going to be short stature for your age. I have a friend who had a pituitary tumor, and she's over 7 feet tall. I've also have friends. Their two twins were born with I don't. It's an unusual very rare disorder, but one of the signs there is too little growth hormone being produced. And so they've been on growth hormone for about the last 3 years. And so sometimes it can be idiopathic or it can be genetic or it can be a tumor or some kind of syndrome. In their case, it was a syndrome. And they are receiving sumatropin, which is humatrope. And you can think about this particular medication. You think of soma, which means body in Greek, soma, and tropin, which is hormone. And so this is a hormone for the body or the body hormone. literally the body hormone. And so you think growth hormone, and so it's the hormone that causes the body to grow. And it can raise blood sugar levels and cause diabetes, so they need to be cautious of that. And so they're monitoring things like their A1C, their blood glucose. And so, they could be, they've gained quite a bit of height, but they may end up gaining some diabetes too. So it's always risk benefit, right? So you want to teaching is you want to give it at night because growth hormone is released at night, and it's their nightly shots. I think they get shots 6 out of 7 nights a week, and it's just part of their routine and has been for a couple of years. But therapy's going well for them. So it's interesting as you start to begin to put some of these pieces together, you'll start to see people in your own life that have different syndromes or challenges. And then if you can think about how can I provide compassionate care to that friend of mine that has this disorder, it will help you in terms of thinking how to do education for them and help you remember things like medications and drugs and so forth, and how to be compassionate signs and symptoms to look out for. You can just sort of picture them, say, okay, if I'm going to be talking to Charlie, what are some things I need to would need to think about if I was talking to Charlie? Not that I would be giving Charlie medical advice, but I can picture Charlie as a patient, and that helps me go, okay, this is what I would do for someone with Cushing's disease or Cushing's syndrome, or this is what I would do with someone with acromegaly or someone with dwarfism or someone with Addison's. And so as you can picture that, that will help you a lot in your studying, not only for pharmacology, but for all of nursing. So let's take a look at some questions and videos here. I've got some pretty good videos, quite a few in here this time because endocrine can be a little tough. So Lecterios, here's just an endocrine overview. Simple Nurse's got a pretty short one here on Cushing's versus Addison's disease and hyper versus hypothyroidism. Level Up Nursing has a good one on growth hormones, corticosteroids, and ADH. And these are all less than 10 minutes. Level Up RN also has one on thyroid and anti-thyroid medications to know. Lecterios Nursing is a good one on corticosteroids. And that's where I took a number of those screenshots, that and Simple Nursing. And then Lecterios Nursing has a quick one here on why you should never stop corticosteroids cold turkey. And if you pick up anything, I want you to remember that because you will see test questions on that all the time. So here's some sample questions. These came from RNpedia, and there are more there. And you can just Google like NCLEX medication questions, endocrine, and you'll find questions and look for some that give you good rationales. And that's a great way to review. So I'm going to take you through a few of these here, and then we'll just kind of look through them. So somatotropin, humatrope, is being given to a female patient for Turner syndrome. And if you remember, that's that when they have one X chromosome. Which of the following findings is associated with this medication? Decrease ALT and AST levels. I don't recall anything that has to do with that. But ALT and AST, those are liver enzymes. What about hyperglycemia? I remember something about hyperglycemia, right? Hypotension. No, I don't think we call anything about that. Water intoxication. No, not that. That would be SIADH, right? So let's go with B, right? Hypoglycemia. And it is. Hypoglycemia, somatotropin, humatrope, is a human growth hormone. Excess bone growth causes insulin resistance and hyperglycemia. Remember, my friends' kids might end up with diabetes at the end of this. And you can remember, soma equals body and tropin equals hormone or hormone stimulus. So somatotropin causes the body to grow up, and it causes the blood sugar to grow up too. It causes the blood sugar to rise up like the height. So maybe that'll help you remember that one. All right, next one. The nurse provides instructions to a client regarding the administration of prednisone and instructs the client the best time to take the medication is during what? Any time of the day, early morning, lunch, or before bedtime. Well, this will be provider driven. Sometimes they'll take it multiple times a day, but if it was one time a day, when is it the best time to take it? Any thoughts? Well, it's early morning, and that's because prednisone is a corticosteroid that is administered early in the morning because it helps reduce adrenal insufficiency and stimulates subversive glucocorticoids released naturally by the adrenal glands each morning. But here's another teaching on it that they didn't teach you about. It can keep you awake. Like it's like drinking 5 Red Bulls. And so you want to take it early as you in the morning, so that it can not interfere with your sleep. Um, but for added review, I want you to go back and without looking, if you can do it without looking, ask why might we give a patient corticosteroids? What are the signs of Cushing's syndrome? Um, and why do we never stop? Uh, why do we never stop glucocorticoids cold turkey? I'm not going to tell you the answers on that. You got to go look it up. All right. So why? Let's do it. So why might they be prescribed things like asthma and other types of autoimmune issues? Signs of Cushing syndrome: moon face, facial hair, buffalo hump, um, mood swings, and things like and what do we need to worry about? An Addisonian crisis. Go back and look at that. It's high yield. All right. Number 3, prednisone is prescribed for a client with diabetes mellitus who is using Humulin 70/30 daily. Which of the following prescription changes does a nurse expect during therapy with prednisone? Well, what do we know about prednisone? Prednisone is a what? SONE. It's a glucocorticoid, right? And so what do glucocorticoids do? They increase your blood sugar. So if we're increasing your blood sugar, we probably should increase your insulin. So the answer is C, increased dosage of insulin. Prednisone is a glucocorticoid. It increases blood glucose levels. Hence, people with diabetes need to increase their dosage of insulin. Remember, cortisol and glucocorticoids increase blood sugar. All right, let's keep going. A nurse is performing an assessment on a newly admitted patient who's taking polythiouracil, propylthiouracil. The nurse suspects the client has a history of what? Okay, what do we know about propylthiouracil? Do you remember that what we're looking for in this particular exam? Right here, THI. What do I want you to remember for this exam? THI for this exam only stands for thyroid hormone inhibitor. So, what medication do we give to someone where we need to inhibit their thyroid? Is it Addison's disease? No. Is it Cushing's disease? Graves' disease? Maybe. Myxedema coma? Maybe. Let's see. These both have to do with cortisol. These have to do with thyroid hormones. Let's see. But which one has to do with too high? Which one's the Graves' disease, the hyperthyroidism? Yeah, Graves' disease. Polythiouracil inhibits the synthesis of thyroid hormone, and we use it to treat Graves' disease or hyperthyroidism. Remember that polythiouracil has a THI. I stands for a thyroid hormone inhibitor. It's not a fast rule for all drugs that have THI in them, but it'll help you remember for this test. So A and B, Addison's and Cushing's, that's adrenal function, and D, that's hypothyroidism. That's hypothyroidism on drugs. And you need to know myxedema coma. It will be in your test. Not this one. If not this one, some test. A nurse is instructing a patient who's taking levothyroxine and tells the client the best time to take the medication is when? Levothyroxine. So what do we see in there? We see the word thyroid. And so we know that this is a synthetic thyroid medication. So when is it best? During bedtime, lunch, with food, on empty stomach. Empty stomach. It's always best to take it on empty stomach, and usually before breakfast to enhance absorption. And so the memory trick, and it's tiny. It's thyroid for thyroid, and it's synthetic thyroid hormone. But it's tiny, again, 50 to like 100 micrograms. And so if it's in the morning on an empty stomach, it eliminates a lot of variables and impact absorption. All right, desmopressin acetate, or DDAVP, is given to a patient with diabetes insipidus. Which of the following is the therapeutic response that you should expect? So let's take a look here. Decreased blood pressure? Well, let's see. Diabetic insipidus might have something to do with blood pressure. Decreased attention span? Well, that's not really relevant. And decreased urinary output? Well, we know that Diabetes insipidus has to do with the amount of urine you're putting out and decreased blood sugar. Eh, looks like A or B is probably the better one, but let's see. Decreased blood pressure. Well, what do we know about desmopressin? It's similar to um, vasopressin, right? And do we give vasopressin to patients that have low blood pressure? Yeah, that's how we treat it. In the ER and the ICU, we give vasopressin. So do we want to decrease somebody's blood pressure that already has decreased blood pressure? Like, no, so that's no good. So we give it to increase blood pressure. So if we're eliminating all of these, the only one we haven't eliminated is decreased urinary output. Do you like that? See how what we did is we took a medication and we're like, what do we know? Let's not collect the right answer. Let's get rid of all of the wrong ones. You should do this with every question too. Um, and so you want to, it's going to decrease urine output. And it's true. So decrease urine output. Therapeutic response to this medication is decrease urine output because it promotes renal conservation of water. And so remember that ADH is the anti-diuretic hormone that helps you retain water. In DI, people don't have enough ADH. They're dry inside. They're super dehydrated. So desmopressin is synthetic ADH, and we give it to help people retain water. ADH causes them to pee less. So if we're causing them to pee less, that's decreasing their urine output, which means they're retaining water, which is what we want this medication to do because they are dry inside and we need them to hang on to that water. All right. A nurse is giving discharge instructions to a patient with levothyroxine or synthyroid. The nurse instructs the client to notify the physician if which of the following occurs. Okay, so what are we thinking about here? What is levothyroxine? Well, let's see. Thyroid, it's a thyroid medication and it's a synthetic thyroid medication. So it's going to increase um, that thyroid. So is cold intolerance? Let's see, why would they be taking that? They would be taking it because they have hypothyroidism. Is that a sign of hypothyroidism? Yep. Is that what they should be doing? Coarse hair? Yep, that's a sign of hypothyroidism. Muscle cramps? Sign of hypothyroidism. So if you want to notify the patient, you probably should notify them that your thyroid medication isn't working. But the one you really need to notify them for, the most important one, is the tremors, because that means they could be having too much. Excessive thyroxine can cause symptoms of hyperthyroidism, which includes heat intolerance. So whatever a drug does well, it can do over well. So hyperthyroidism is heat intolerance, tremors, nervousness, tachycardia, chest pain, hyperthyroidism. And so we use levothyroxine to treat hypothyroidism, but if we give them too much, we will see these effects, right? If we overdo it, we'll put them into a hypothyroid state. And because it's such high mileage, I want you guys to take a little quick diabetes review. I've got 3 questions here for you. A nurse is teaching a patient on how to mix regular insulin and NPH insulin in the same syringe, which the following, if performed by the patient, indicates a need for further teaching. So when you see indicates a need for further teaching, it means they're doing something wrong. So what are they doing wrong here? Withdrawing the regular insulin first. Is that okay? What about withdrawing the NPH insulin first? Okay, so if you ever see a question that has 2 opposites, one of the opposites is probably the answer you're looking for. So you can probably then just eliminate C and D without looking at it, but let's do. Injects an amount equivalent to air into desired dose of insulin. Yeah, that's good. That's a good thing to do. Injects air into the NPH insulin first. Sure, that doesn't really matter. But what are we doing? We always want to withdraw which one first? Regular. So um, we want to withdraw the regular insulin first. And so needs for further teaching means they're doing something wrong. So which one is wrong? This is the one they're doing wrong right here. They're withdrawing the NPH first. That's not right. We always want to draw clear before cloudy. Regular insulin is drawn into a syringe first, then the NPH, because that avoids contaminating the regular insulin. So remember, clear before cloudy, or regular or short before cloudy, intermediate. And you can think about this as RN, regular, registered nerve. Which of the following insulin cannot be mixed with any other type of insulin? Insulin glargine, insulin aspart, insulin lispro, regular insulin, or NPH insulin. Um, the answer is insulin glargine. It's the only one that can't be mixed with the other type of insulin. And for added practice, it's just the long-acting one. But I want you to go back and take a minute and categorize rapid, short, intermediate, or long-acting, and give the peak times if appropriate. So I want you to go back and take a look at the handout from last week and notes, because you will see these questions. You will. All right. A client with diabetes mellitus is prescribed exenatide or butyrione. The nurse will do which of the following appropriate actions? A, withdraw the insulin from a pre-filled pen into an insulin syringe. B, monitor the signs of nausea, vomiting, and gastric upset. C, administer the medication twice a day during pre-meals. And D, hold the medication and call a physician for the prescription. Now, you might not remember this medication, but the answer is D, and that you want to hold the medication and you want to question it, because exenatide is only used to treat diabetes mellitus type 2, which is not always, don't usually give it, and you never give it with insulin. So remember from last week that you do Xnay on the exenatide. Xnay on the exenatide, okay? So if you see that, I want you guys to know that, because I remember a test question like that. So you need to know that. It can cause hypoglycemia. All right, friends, that's it. Talk to you later.